It's live. It's just going through the final loading stage.
Okay.
And spinning. Okay, and we are live. Good evening, web shadowers. Thank you all for joining our session today. Today we have the pleasure of hosting Dr. Rashmi Advani, who will be presenting on gastroenterology. As always, please remember that the Google form for attendance will be pasted into the chat box at the very end of the session. With that being said, Dr. Advani, you can get started whenever you're ready.
Awesome. Sophia, thank you so much for the introduction. Web shadowers, I just want to thank you guys for arranging something like this for your pre-meds and allowing a shadowing opportunity virtually, especially during these pretty difficult times. So a little bit about me. I am currently a second year GI fellow. So I completed medical school, and then I did 3 years of internal medicine residency. And then after that, you can choose to either work as an internist or a hospitalist or in primary care, or decide to specialize. And I wanted to specialize. So one of those fields of specialty is gastroenterology. And one of the major reasons why I chose it is because it is a really, really cool specialty, and you get to do procedures and really link pathology to your diagnosis. And today we'll be going over a really important case, something that I think even as in pre-medical school that you should be familiar with. And I think it kind of highlights how we relate pathology to the procedures that we do. All right, I'll start. And feel free to ask questions along the way. I'll do my best to answer them as they come in. And this will be a little bit interactive, so I'm going to definitely ask you guys questions and just do it that way. So it'll be a little bit more fun. All right. So I just wanted to go over a little bit about the gastrointestinal anatomy. When I was a pre-med student, I really didn't know all the components, and I think even like through anatomy, you learn about the GI tract, but you don't really fully appreciate what its components are. So the GI tract goes straight from all the way from the mouth to the anus, and some of the organs that are not necessarily in that plumbing system that you see are the liver, the pancreas, the gallbladder, but all of these organs do drain into the GI tract, the main GI tract. So from start to finish, you start with the esophagus. So you have the esophagus, you have the stomach, you have the small bowel, which is over 20 meters long. And then you have the large colon. So the large colon, you can see it's labeled there, and then it terminates in the rectum and the anus. And in GI, the way we evaluate patients who have disorders that involve any of these organs is through lab tests, through stool tests, through their clinical exam, through the physical exam, and mainly through endoscopy. And I'll go over essentially what endoscopy is, but there are two ways we can access the GI tract, either from the top or the bottom. It's one plumbing system. It's really not much to it, but we can really do a lot of things in GI. And the most exciting thing about the field right now is that in the last 10 years or so, we're coming up with ways to perform procedures that typically surgeons would perform, and patients are having better clinical outcomes. They have less duration of hospital stays. So it really is a booming field in medicine. All right. So the next part of the anatomy, I wanted to focus a little bit on the stomach, just because our case is going to involve the structure in the GI tract. So as I mentioned, the esophagus feeds into the stomach, and the stomach has several components to it. So if you look at the top of the screen, you have something called the cardia. And that's really at the beginning of the stomach. And then you have something called the fundus. So the fundus is really the cupped area of the stomach. Then you have something called the body of the stomach, and that's really where I'm pointing to here on the right side of the stomach. We call it the greater curve. If you can tell, it's the greater of the two curves. There are two curves. This lesser curve here on the left side, and then there's a greater curve. And then you enter this area called the antrum, which is after the curve of the stomach, and then you reach the pylorus. And the pylorus is really that opening of the stomach that allows food to travel from the stomach into the small bowel. And as I mentioned earlier, the small bowel, it's a very long tube, and there are three major segments to the small bowel. We are only really able to evaluate the duodenum in our standard endoscopies, but really the duodenum is the first segment that comes after the pylorus. So when we're looking at pathologies, especially for this case I'm about to present, I want you to think about this anatomy and really about how we can assess pathologies in this area of the GI tract. So the standard upper endoscopy, we can reach these areas in the stomach and the duodenum, and if there's any issues, we can treat whatever pathologies that there might be. We can take biopsies, we can do clips, you can do a lot of things. So each area of the stomach that I mentioned has its own function, its own purpose. They have its own biochemical purpose, and its own like physical purpose. So the fundus usually is the dependent portion of the stomach. The stomach really isn't a 2D structure, it's a 4D structure. So there's parts of the stomach that sit more posteriorly, and there are parts of the stomach that sit more anteriorly in the body. So this is a visual representation of what the stomach, kind of looks like on paper, but endoscopically and the true anatomy behind it, when you guys do your anatomy classes or do your cadaver labs, you'll see that the stomach doesn't look like this. It looks more 4D. All right, so I also wanted to show you guys a picture of what each part of the stomach looks like in endoscopy. So as I mentioned earlier, we have the way we can evaluate the esophagus, the stomach, the duodenum, the first portion of the small bowel, is through endoscopy. And I mentioned again, essentially these the way it looks endoscopically is not the way it looks like on paper, like most things in the human anatomy. So the fundus, as I mentioned, the dependent portion, usually, so if you look at panel B, it's the retroflexed version view of the fundus. So it's really like you're taking your camera and you're looking back and you're seeing what it looks like. And then the stomach is full of these folds called the rugae, and that's one defining feature of the stomach, that you're in the stomach, because they have these like very thick folds, and really those folds are meant have multiple functions, and I'll go over what those are. And the pylorus really is this hole, and this hole, it's at the end of the stomach, and again, it's this entry point for the food to go from the stomach into the small bowel. And this pylorus can, open for food to pass through, and then it can close off, when it needs to. So the first portion of the small bowel, as I mentioned, is the duodenum. And really the defining feature of duodenum is these circular folds. So these circular folds actually exist throughout the small bowel. And then the small bowel feeds into the colon, the large colon. But the defining feature of the small bowel are these like circular looking patterns. And then the mucosa itself, on our images, it's, if you guys know about this already, but the small bowel has villi, and these villi are these like finger-like projections, and they help with absorption, they help with breaking down of food. So lots of function in the GI tract. So the function of the GI tract, especially the stomach. So you have two main functions, two main components of essentially food transit. So and digestion. One of them is luminal secretion of certain um, uh, molecules, and the motility component. So you have to have both in order to have proper digestion and proper motility and passage of food. If something in these two right panels goes awry, then that's where you run into trouble. That's where you run into different types of diseases and pathologies. So one of the main functions. So as I mentioned, each part of the stomach has its own function. And the LES really means the lower esophageal sphincter. So that's that sphincter where the esophagus ends and then the stomach begins. And the first part of that stomach I told you was the cardia. So in that area alone, the mucus layer of the stomach produces bicarb. And then the motility of that area, it really prevents food from going back into the esophagus. And it's an entry point for food. So that's where food goes in, and it's regulated by the esophagus. And then it's even when you're like belching, so that's kind of the mechanism that is involved when you are burping. So the fundus in the body, so the fundus, as I mentioned, is that cup portion of the stomach, and then the body. It has additional molecules that the cells secrete, like intrinsic factors used for B12 absorption, pepsinogens, so basically to break down protein in the food components that enter the stomach, lipase. So lipase is also a part of that. And really the motility component of this, it really acts as a reservoir, so storing of food. So, if you eat a meal, most of your food is sitting in the body, in the fundus, and that's really when you start feeling full, when those areas start getting full. And really it helps with not contracting really, but like it keeps like a tonic force on the food passage. And then the antrum and pylorus, really, again, you have secretion of bicarb, and there is really where like all of the food starts mixing and grinding, and then that area regulates the emptying. So I just got a question that does a pylorus prevent backflow? And yes, so like every sphincter in the GI tract, it's regulated by nerves that come from the brain, that come from the gut itself, the parasympathetic and sympathetic nervous system. Mainly the parasympathetic nervous system regulate the flow, and the nerves kind of like allowing the muscles to contract or relax. So there are three main sphincters in the GI tract. As I mentioned, the first one is the lower esophageal sphincter that's supposed to prevent reflux. The pylorus prevents backflow of food from the small bowel into the stomach. And then you have the ileocecal valve. So ileocecal valve is at the end of the small bowel, and that valve connects the small bowel to the large bowel. So usually when we do our colonoscopies, we can even assess that area of the valve. So especially patients who have inflammatory bowel disease like Crohn's, ulcer colitis, we're always looking in that area. Even patients who are bleeding from the GI tract, we generally look in that area if we're doing a colonoscopy. Further, a little bit more about function, and I promise it's the last like pre-slide before the case, but as I mentioned, there is a mucus barrier in the stomach, and that mucus barrier acts in two ways. One of them is that it creates a physical barrier for all the acid that's in the gastric lumen, and prevents it from reaching the cells on the bottom, because the acid really in the lumen is meant to digest the food. but that acid can be extremely corrosive to the cells underneath. So there's a mucus layer that separates the two. And the mucus layer, not only does it create a physical barrier, it also creates a biochemical barrier, meaning that it actually ends up neutralizing the acid in your stomach and converts that to water and carbon dioxide. And sometimes that also is manifested in burping. So another thing I do want to say is that, the GI tract is lined with bacteria, and those bacteria typically live above the mucus layer. So you can imagine a situation where if a mucus membrane is compromised for any reason, you create a passageway for acid to reach the cells underneath and cause damage, and you also create a passageway for potential pathologic bacteria to reach the cells underneath and also damage and cause inflammation. And really, the inflammation component of this is part of the case today. And inflammatory cells come from the blood vessels that feed this area of the GI tract. And those inflammatory cells will come in and they'll release their cytokines, and they'll wreak havoc on this whole beautiful process. So really, the mucus barrier is an important component of protecting the cells underneath. All right, so I'm going to go into the case. We have a 35-year-old woman with a history of knee pain, and she presents with black stool for one day. So she says that she has had about 4 episodes of this black stool, and that's been since the morning. And she's now feeling fatigued and dizzy. On further history, she's also been having abdominal pain for 2 months that led up to her presentation. And so really, this is a point where you're looking at a case. It's a young woman, and she has knee pain, and she has black stool for one day. And you know that stool looks brown, right? And it shouldn't really look black, and it shouldn't look red. So there's definitely things that on your differential you want to think about, but I'll go through the next part of the case, and then I'll start asking some questions. Okay. So on further questioning, she denies any vomiting, no red stool, no fevers, no chills, no headaches. She denies any trouble swallowing, no weight loss. You do a thorough history on her. And one thing that's important in medicine is to really get a thorough history of your patient, because it's really easy to premature close, especially if you're looking at pattern recognition. And yes, there is a method to the pattern recognition, but there have been more times than I can count that I've premature closed on a diagnosis and it wasn't that diagnosis. So something I just want you guys to keep in mind about when you're taking your history. So medication, she's been taking ibuprofen over the counter, 400 milligrams 3 times a day for 2 months. She's also been taking vitamin D supplements. She's never had any surgeries. Her family history, she said her mother had some cancer in the stomach, but she doesn't remember much about that or the age of her mother's diagnosis. And her father was also diagnosed with colon cancer. Also, she's unfamiliar with what year, how old he was when he was diagnosed with colon cancer. There are other components of the family history, but for GI specifically, we ask about cancers of the GI tract or any issues with the GI tract. So we also ask about whether family members have had inflammatory bowel disease, because that really helps us in our assessment and risk stratify the patient. But anyway, she has no allergies. Her social history, she denies any alcohol use. No, she doesn't smoke. She doesn't use any cigars, no vaping, and she doesn't use any illicit drugs. And medical history, she has patellofemoral syndrome. So what is the next component of your evaluation for this patient? That's my first question to you guys. In the meantime, I'm going to answer a question that just came in. So the question is, how much of an impact does eating frequent fast foods and alcohol have on the diversity and quantity of the gut microbiome or gut microbiota? And really, that's a really good question. And it's a pretty loaded question, but in short, what I can tell you guys is that you definitely want your organism population, the GI tract, to be as diverse as possible, because that diversity will allow digestion to occur better and naturally. So if you're doing anything that can affect the gut microbiome, like taking antibiotics or having multiple gut infections or having even food poisoning, can affect the bacterial population in your stomach and your GI tract, leading to different types of GI symptoms like diarrhea, constipation. We see this actually a lot. I usually patients who ingest alcohol and they're having GI symptoms, and I recommend anyway for them to cut down on alcohol, but I definitely do suggest that they reduce their alcohol intake, because that could be contributing to that. And also alcohol has a bunch of other GI side effects and pathologies related to its excessive use that you really want to avoid. Okay, so I got the answer. Physical exam, blood counts, look into knee pain, lab work, ask about pain management as it's the high dose of ibuprofen. These are really great. These are actually pretty good. So, right, so the next component of, and some other answers, we got abdominal ultrasound, fluid testing. Okay, so someone's thinking about ascites and cirrhosis. So those are great answers, guys. So you're right. We'll look at the vitals in the physical exam. So you really want to know the first assessment of your patient, no matter what field of medicine you're in. You want to see how sick your patient is. So one thing that the medical schools and even like the exams that you take and the boards that you take is your patient sick? Are they sick? Then it sets you down this whole other set of like management. So the way to determine if someone looks sick is definitely look at them, see them. What do they look like? Do they look like crap? Or what are their vitals? So so her heart rate is 110. That's a little bit elevated from the normal range of 60 to 100. Her blood pressure is 110/70. So, that's pretty normal for a 35-year-old. I didn't mention her weight, but she's an average sized woman. She's afebrile, so she doesn't have a fever, and she's saturating 100% on room air. She's pretty comfortable. So her physical exam, so there are different components of the physical exam. There's a cardiac exam, there's a head and neck exam, there's a respiratory exam, there's a GI exam. And part of the GI exam that we focus on is what the abdomen looks like. So her abdomen looked benign. She wasn't tender, and she had no rashes on her abdomen. It wasn't distended. Her rectal exam. So this is something that if your patient is complaining of black stool and that's not normal, I usually ask the team taking care of the patient to make sure they do their rectal exam and see what the stool actually looks like, because sometimes stool can look dark or black in like a dimly lit environment. So usually I ask them to take a take lubricant, put it on their finger, and you only use one finger for your rectal exam. And when you do your rectal exam, you have to look at several components of that. So you look at the tone of the anus. If the tone is good, if it's normal tone, you check around for masses when you put your finger in, and then you ask the patient to actually bear down. So you actually push, like they're almost making a bowel movement, and you try to, it reduces like the amount of discomfort that they have, and B, you'll get a more accurate sample of what's going on in their stool. So I usually ask the residents to get a sample of the stool and put it on something white. So if you put on something white, it gives you the actual color of what the stool looks like, because sometimes bile could also look really, really black. And bile is normal. Bile goes through the GI system. Okay, so the next question I have for you guys is, what is the next step in this evaluation? Okay. In the meantime, I'm going to answer this question. So what was the patient's reasoning for the ibuprofen intake? So that's good. Having a complete history and as to why patients are taking the medications, that especially if they're not prescribed certain medications, is really helpful. So she has patellofemoral syndrome of her knees, and her knees hurt. So she's been taking ibuprofen to help with her knee pain for many, many months. And then she started having abdominal pain 2 months ago, but it totally ignored it. But yeah, I totally agree with whoever had stated this, that the ibuprofen could be the underlying reasoning for her presentation. So that's a really, really good thought. And I can, we'll go over kind of like what are the pertinent parts of the history that you just took. Okay, so I got some answers. So CBC, colonoscopy, endoscopy, BMP. Yeah, so these are really good answers. So, we generally don't jump straight to procedures because, again, procedures, there are risks associated with procedures. We have to give anesthesia to the patient. So we have to do a thorough assessment and make sure it's safe for the patient to undergo a procedure. And which is why, we take all these next steps into consideration. So the labs are the next step in your evaluation. So we noticed that I'm only going to talk about the pertinent labs, but as you know, CBC is a whole panel of results. So you have the white count, you have the hemoglobin, the hematocrit, and the platelet count. And her hemoglobin is 8 grams per deciliter, and her baseline is 11. She's a normal menstruating young woman, but she's typically around 11. And that's something that, especially in GI cases and potential bleeder cases, you want to look at the trend of their hemoglobin. Like, what was their last hemoglobin? Because 8 could be someone's normal, but 8 in her case is not her normal because she's normally 11. And her platelet count's normal, her white count's normal. And then someone mentioned BMP. So that's correct. The creatinine is part of the BMP. And the BMP has several components. Mainly, it's the sodium, the potassium, chloride, bicarb, the creatinine. And then you have the complete metabolic panel that includes the liver enzymes. The liver enzymes are your ALT, AST, your alk phos, your total bilirubin. So those are the main components of the liver panel. And then you also have something called the coags. So those are the coag lab results. So that includes INR. So the and then also PT and PTT. So looking at all of those is important and part of your evaluation of looking at the patient's laboratory results. So when we go over the rest of her labs, her sodium, her platelets, her INR, her potassium, her liver panel, white count, everything is normal. So that's something that also could keep you at a little ease, but her creatinine is 1.4. And we know that that's not a normal creatinine. Well, I know it's not normal. And usually creatinine, a normal creatinine in a young, otherwise healthy adult is anywhere from like 0.7 to like 1.2. So 1.4 is a little bit on the higher end of normal. And the creatinine really has to deal with how you're clearing out this in the body. So if your kidneys aren't functioning well, you don't clear out enough creatinine, so your creatinine goes up. And it's an indirect marker of kidney function. All right. Okay. So is there anything else that you guys want to do? Would you get any imaging? What's on your differential? We'll go over each of these questions, but I want to ask you guys, so like what do you think are the pertinent positives or pertinent negatives of the case that you just heard about? And what data support or refute your components of your differential? So really a differential is something that we talk about a lot in medicine, and it really means that like if you have a patient present a certain way, like what are the potential reasons why they have this issue? So in medicine, nothing is black and white. There's a lot of gray, but in medical school, you do learn a lot of these uh, pathologies. It's all about learning what each patient can present as and what to do and how to manage that. So the management part in medicine comes much later in your training. So after medical school, you learn that as a resident. So I wouldn't worry too much about the management of this, but I definitely want you guys to try to give me some answers on like what you think is going on or what, what's in your differential. Okay, so I got an answer, abdominal CT with focus on the kidneys. Potentially, imaging might not be super helpful in this case just because, she is having black stool. She might actually be bleeding. So an abdominal CT with a focus on the kidneys might not give you the answer that you want. But really, it was a trick question. I don't think you shouldn't get any more imaging in this case because even though the creatinine is a little bit elevated, going down your differential, what could be going on. So we know that she's bleeding. We just don't know from where and how and why. Although we could have a pretty good idea as to why. But someone responded, GI bleed from ibuprofen, stomach ulcer. Yeah, so these are definitely part of your differential. Is there anything else in your differential that you guys are thinking of? Definitely. So I got another answer, problems in the upper GI tract, definitely. Are you guys thinking about like any other types of diagnoses or issues that could be going on with her? So GI cancers, yes. Hepatitis is a good thought, but her liver enzymes are completely normal. So usually hepatitis, itis means inflammation. And when you have inflammation in the liver, those liver enzymes go up. So her liver enzymes are completely normal, but definitely something to think about. I got an answer of hemorrhoids. That's a really, really good answer. So definitely, things that bleed are part of your differential. when someone's in the GI bleeding world, when you're thinking about bleeding per se, the black really means that whatever is bleeding had time enough to digest through the GI tract in order to turn black. So in your mind, something is happening in the upper GI tract. And could that be a bleed? Could it be a fast bleed? Could it be a slow bleed? But hemorrhoids are these dilated blood vessels that develop in the anal region. And those typically, when they bleed, they have a short distance to the outside world. So they come out as red, so bright red. So definitely, hemorrhoids are things that can bleed in the GI tract, but they present more with bright red blood stool. Good. H. pylori, definitely. So these are really good answers. You guys are already on your way to being gastroenterologists. So, okay. So pertinent positives and pertinent negatives. So we have, some of the positives that we know is that she's taking ibuprofen. She's young. She's had some abdominal pain for 2 months. Whereas her abdominal pain was epigastric, although she wasn't tender on exam, but it gets you thinking. Pertinent negatives. So she has black stool, not red stool. So you're not thinking about a lower GI tract issue. You think about something in the upper GI tract. So all very good answers. Okay, so your next step in management is an upper endoscopy. Yay, so whoever answered that, kudos. And I'm sure all of you are thinking that as well, that we were gonna get there eventually, because it wouldn't be a GI case if we didn't have endoscopy part of it. So, but one thing is that before, like I mentioned earlier, you don't wanna just do a procedure on someone that you haven't fully evaluated, right? So in her history, her physical exam, she's a little tachycardic, her hemoglobin's 8, she's still having black stool. So there are a few things that you need to do before you just take this patient to the endoscopy suite, because again, it's a procedure. They get anesthesia. Anesthetics can drop your blood pressure. So, and there's a vagal response when we place our endoscope, our endoscope. So that can even drop the pressure even more. So you want to make sure your patient is primed and ready to go, and there aren't any hiccups along the way. So part of the management, you want to give them some blood. PRBC really just means packed red blood cells. So you want to give her packed red blood cells. Give her 1 now, and then definitely some later if she keeps bleeding. You want to make sure they have good IV access. So when it's important that your patient has working IVs, because if you're giving them blood, if you're giving them fluids, if you're giving them anesthesia, if anything happens emergently, you want to make sure they have adequate access. So we always say patients should have a 20 gauge, 220 gauges or hot, or thick or larger in their veins. So 18 gauges, 16 gauges are fine as well. And then, does the patient have any coagulopathy? So when I mean by coagulopathy, I'm talking about INR, PT, PTT. I'm also looking at the platelets. So do they need any blood products like FFP, which is called fresh frozen plasma? And really, one of the main components of the management for something of this nature is pantoprazole. And pantoprazole is a proton pump inhibitor. It is a medication that we typically give to reduce acid exposure in the stomach. So whoever said that this patient has a stomach ulcer or an ulcer is right. Usually people who have ulcers can bleed because ulcers, they can erode into the blood vessels underneath, and those blood vessels can bleed. And depending on, we already know that she's been taking ibuprofen, and ibuprofen is an NSAID. It's in the NSAID category. And NSAIDs are typically known to break down that mucus barrier. See, there's a whole reason why we talked about the mucus barrier earlier. And the NSAIDs are known to break down that mucus barrier. So she took NSAIDs, and she broke down her mucus barrier, and she created an ulcer because she had inflammation there. The acid damaged those cells underneath, and she caused an ulcer. And that ulcer got deep enough that now it's bleeding. So, and then the other thing to ask is, when did they eat last? Because that allows you to determine whether you need to protect the person's airway when you're performing a procedure. So a lot goes into the pre-assessment prior to your procedure. Okay, so endoscopy. So the reason why I wanted to show you the guys' slide is because when I was in your shoes, even as a medical student, and to some degree, even as like a internal medicine resident, I didn't have a clear picture as to what an endoscopy was and how it looked like, what the setup was. So I just wanted to show you some pictures about this, and so you have an idea of exactly what we do and how we do it. So on the left side, you see your patient. They're lying on their left side, and so the person that's holding basically the endoscope, that would be someone like me doing a procedure. So you put the endoscope through the mouth, and you go through the esophagus to reach the stomach, like I mentioned. And if you look on the right images, that's how you do it. And then the scope that we have has a light and camera at the end. So that light helps us see, because our internal structures aren't naturally lit inside. And so we have to light it up. And then we also have a camera to take pictures. And then there's also another part of the device itself. It's our channel. So essentially anything that we need to do in terms of injections or clips, we can snake it through those channels and accomplish whatever we need to accomplish that way. So I got a question. How common are stomach ulcers? Okay, so how common are stomach ulcers? So they can be pretty common. I see them quite often, and I see them for a variety of reasons. In the United States, I see them due to alcohol use, NSAID use, and sometimes H. pylori, just because a lot of the populations I've served in the past are underserved. They're immigrants. So H. pylori is a pretty common reason for ulcers in non-developed countries. But I do see it here as well. And the next question is, do they place you on your left side during an endoscopy to prevent reflux? Or what is the specific reason for laying on the left side? That's actually a really good question. So I actually had this question too when I first started. And the reason why is, one, to prevent aspiration. So aspiration is really any contents of the stomach going into the airway system and causing aspiration. So you can get, the acid can cause something called aspiration pneumonitis. So like irritation and inflammation of the airways. You can also get pneumonia from that. And the left side also allows us to view the structures of the stomach, because the stomach, as I mentioned, the fundus is a dependent portion of the stomach, so it allows us for easier access. But the main reason is to prevent aspiration. Are pill camera endoscopies becoming more common for diagnosing disease of the small bowel? That's also, you guys have such great questions. I love it. So with pill camera endoscopies, so the pill system has been around for about 15, 20 years now, but and it just gets better and better, the resolution and the battery life. But really, it's it's the size of a multivitamin. The patient swallows it, and there's an external monitor with EKG, large EKG looking leads, or even a belt that monitors kind of the images as the capsule goes through the small bowel. And there are a lot of diseases of the small bowel that we evaluate non-invasively through the pill camera system. So that's definitely part of our evaluation. For this particular case, it's our suspicion is pretty high that whatever's happening is either in the stomach and the duodenum. It's pretty reachable, so we're going to use a standard upper endoscopy. All right, so here's some cool images. On the upper left, there are some images of ulcers that I was mentioning. So these ulcers, they're in the stomach, and the reason why I know this is in the stomach is because of the rugae. So you see these folds, and you don't see the villi like you would see in the duodenum. On the right side, you see a bleeding ulcer. So the red spot in the center of that is the ulcer, and uh, and then on the bottom panel, you have a squirting, basically blood vessel, um, um, and that's also in the stomach. Sorry, give me 1 second. Okay, I apologize. So really these are the pictures of what bleeding ulcers look like in the stomach and then also in the small bowel. So peptic ulcer disease, this is, so as I mentioned, this is the two main causes of peptic ulcer disease in both the stomach and in the duodenum is through NSAID use and through H. pylori infection, but other potential causes are stress ulcers and alcohol use, family history, malignancy, and something called Zollinger-Ellison syndrome. And that really are the other causes of peptic ulcer disease. But the main ones, as something that I definitely want you guys to try to remember, is NSAID use and H. pylori infection. Okay, so as I mentioned, ulcers can occur both in the stomach and the duodenum. So our patient, I don't really, like before even doing an endoscopy on her, I didn't know if she was having an ulcer. I knew she had a bleeding ulcer, but I don't know if it was happening in the stomach or in the duodenum. And really NSAIDs can cause ulcers in both locations. So in the stomach, people who have ulcers, there are a few classic symptoms that you can probably, think about and maybe ask your patients if they have these symptoms, especially if they just have abdominal pain and no like bleeding. But gastric ulcers usually manifest with pain that's increased with any meal. It's not as common, and patients usually have vomiting. And the duodenal ulcers, there's a pain relieved with meal. It's more common. It's usually associated with H. pylori and usually manifests as dark tarry stools. So that's usually kind of like the two locations where you would find a peptic ulcer and the different reasons. So if I see a gastric ulcer, there's something else that I do think about is malignancy. Usually malignancy associated ulcers don't really occur in the duodenum, and they usually occur in the stomach. So I always take biopsies, especially if it's an ulcer that kind of looks a little, there's no reason. The patient hasn't described any history of NSAID use. They have negative H. pylori. I definitely take biopsies to take a look at that to make sure it's not cancer. I got a question. So is there a known pathophysiology for how stress causes ulcers? So I think it has to do, I don't think anyone really knows why, but there are a few theories behind it. One of them is that the blood flow to the GI tract at that time can be affected depending if someone has hypotension or they're critically ill in the ICU. And some other reasons would be if like certain medications compromise the mucous membrane barrier when patients are sick. So a lot of patients who are sick in the ICU also sometimes are given steroids, so that can also cause ulcers. But stress ulcers, there's also something called a curling ulcer that happens in patients who have neurologic injury, and again, the pathophysiology, I can't exactly recall if there's a known one. I remember when I was learning about it, there wasn't one. It was just something I had to remember. But yeah, those are the situations where you can develop stress ulcers. The next question is, are ulcers totally curable, or are they just typically managed? Yeah, so the idea behind learning about the cause of your ulcer is important because if it's NSAID use, you just tell your patient to stop using NSAIDs. If it's H. pylori, you treat the H. pylori. And if it's from other causes, then you would have to, like alcohol use, then you would tell them to stop drinking alcohol. But the treatment is to put patients on pantoprazole and twice a day dosing at least for 8 weeks. Another question is, when it comes to bloody stools, under what circumstances / combination of symptoms warrants a medical emergency? So as I mentioned earlier, if someone is sick, meaning like if their vitals are unstable, if they're tachycardic, like for her, she was tachycardic. Her blood pressure was like on the lower side, even though it could have been her baseline. But I would say, and if they have ongoing evidence of bleeding, I think my threshold to perform an endoscopy is a lot lower. All right, so here's a picture of where ulcers can sit in the stomach and the duodenum. In the duodenum, it's usually in the bulb, the first portion of the stomach. It could happen in the fundus in the body, and also the antrum, which is close to the pylorus. In H. pylori, essentially, it's not NSAIDs that break the mucus barrier, but it's the organism itself. So if you have H. pylori infection, it breaks down the mucus barrier and causes acid to pass through and cause damage. So more or less kind of like the same pathophysiology, but with a big breakdown of the mucous membrane barrier, but through different mechanisms. Okay, so when I'm basically done with my case, there was a quote that I was asked to provide, but one thing I can impart to you guys is that there are 4 key ways to becoming a great doctor. Finding ways to keep learning, avoid premature closure, be compassionate, and be curious. And that's something that in my entire years of training and schooling, now looking back, these were the 4 main things that I took away from my experiences. So thank you so much. I am going to end here. But I'm happy to answer questions for the next 5 minutes. If you guys have any questions or you want to learn a little bit more about GI, I have an Instagram account under Dr. Scopes with Guts, and feel free to ask me any questions there. Especially if you're interested in medicine and gastroenterology and the exciting, cutting edge procedural specialty of gastroenterology. We definitely, definitely want young, brilliant minds to enter the field as well. Okay. Can you talk about your journey to becoming a doctor, undergrad, medical school, gap years, etc.? So I was actually talking to Sophia earlier, but I did take a gap year. In my college, I finished college in 3 years, so I took the extra year to kind of just do everything else aside from medicine. And I just traveled. I worked for a restaurant, so I taught dance. So that was really nice. And undergrad medical school, I was in New York. I am in New York, and I've done all my schooling in New York, including undergrad, medical school, residency. So I'm now 5 years out of medical school, and I'm on my way to pursuing an extra year after gastroenterology fellowship, which is total 3 years. So I have another year of general fellowship after this year. Okay, so what's my typical workday look like? So my typical workday looks like depends on what rotation I'm on. So as a first year GI fellow, definitely inpatient consults. So you're seeing very sick patients in the hospital. So I usually get to work around 7. If it's a good day, I leave at 5. If it's not so good day, maybe like 6:37. If there's emergencies, and we usually do that. We do have you are on call as a, as a doctor. And I think in GI, we take home call. So unless there's an emergency, that's only the time when you go into the hospital to do a procedure. So, and then in clinic, usually the days run from like 8 in the morning to like 5:30, 6 in the afternoon. So it's really not terrible at all. It's really, I think GI has a pretty nice lifestyle. It's pretty versatile. You could really make, it's one of the few fields in medicine where you could really make what you want to make of it. And it has such a stimulating pathophysiology backing to it. And it's really one of the few medical specialties where you can use your medical knowledge and correlate that to your diagnosis and also correlate that to what you see endoscopically. So that's the really cool thing about GI. I'm rapid answering these questions. So what were the differences between your residency and fellowship? So residency, it's an internal medicine residency. You're learning everything, different components of medicine. And fellowship, it's more specialized. So you're learning, strictly your specialty and how to, it's a learning curve. I think both areas are its own like sets of challenges and like experiences. Residency, you're learning just kind of, you're starting to become, you're trying to become comfortable, people starting to call you doctor, and you're trying to take care of patients and learn differentials and management. So and in fellowship, it's a little bit of that, but like it's a little bit more where you're just having a different set of responsibilities. You're essentially attending by fellowship, you're just choosing to kind of like specialize. So it kind of just takes a different take on things. And you're more one with your colleagues versus like, this is like you're attending versus like a resident in residency. So that's the difference between the two. There are many other differences, but I think those are the main ones I'd like to highlight. Obviously, if you have any questions with that, you can reach out to me on Instagram. Best tips for avoiding burnout: sleep. Make sure you sleep, guys. That's something I can't stress enough in training in medical school. Like, don't compromise on your sleep, because I feel like you're not your best self if you don't get if your body doesn't get the rest it needs. And don't skip on meals. Like, it's really easy and it's easier said than done, and I've done it a ton of times and I've regretted it every time. But I would say just if it's something where you could just like pack a meal, just bring it to work, have a sandwich on the go. Like, if you're really busy, just don't compromise on that either. And throughout my training, I've always maintained my relationships with like my like kindergarten friends and like my family. So those people are like my crutches, especially throughout training. It could be pretty immensely mentally, emotionally, physically demanding. And there are waves, like there are ups and then there are downs. And I think you can't have your ups without your downs. So don't let that deter you away from the field, because I definitely think we really need people with compassion and kindness, and who just really want to help patients. I think we would really benefit from that in the field. That's pretty much it. Those are my concluding thoughts. Again, if you guys have any other questions, reach out to me. I'm on Instagram. I'm also on Twitter. I don't know how many of you guys use Twitter, but that's my more professional page. If you're looking for like articles and GI and stuff like that, I post a lot there too. So that's pretty much it.
Thank you so much, Dr. Advani. This was a wonderful and super informative presentation. Thank you so much for taking the time to answer all of our questions. I know everyone learned so much from you. For everyone watching, the Google form has been posted in the chat, and it'll be open for another 30 minutes. So I'll close it at 8:33. And thank you so much again, Dr. Advani. I hope
my pleasure.
you have a wonderful rest of your day.
Thank you, guys. Thank you for being so interactive. It's been a pleasure. Sophia at Web Shatterers, thank you again for having me.